Okay, ma'am, we can start.
Hello friends, today going to address and touch upon an interesting subject of recurrent biochemical pregnancy, the unsolved mystery. It is not very uncommon, rather we often see this in our day-to-day practice. It comes with a lot of bundle of hopes and joy and happiness and celebrations and ultimately ends up in a lot of disappointment and despair. So this is biochemical pregnancy. After this, we keep pondering as to what really happened in the case of this pregnancy and what is going to happen in subsequent pregnancy. Since very few studies are there in the literature and etiology has not yet proven, therefore it is an unsolved mystery. What are the concerns? There are great concerns from the patient's point of view and from the doctor's point of view. From patient's point of view, what is the cause? Why did this happen to me? Implications of this pregnancy on subsequent pregnancy. Is my uterus defective, doctor? Will I never have a baby? And from doctor's point of view, we always think, what next? How are we going to treat this couple for the next pregnancy? And how is she going to achieve her motherhood, or they are going to achieve the parenthood? So this is a challenging situation for all the treating doctors, and therefore, let us learn a little more about the subject. Actually, what is a biochemical pregnancy? It is transient rise in beta HCG. Pregnancy is diagnosed only by chemical means, that is a urine test, or more precisely, a blood pregnancy test, and lack of clinical detection of this pregnancy, which is not further visualized on ultrasound. So this is what is a biochemical pregnancy, so that the woman is pregnant, but ultimately it is really not shown. It could be an initial pregnancy test being positive, but fails to a clinical pregnancy, or a pregnancy test which is positive, followed by a negative report. How to differentiate a biochemical pregnancy from pregnancy of unknown location, or chemical pregnancy versus clinical pregnancy? These are the issues that we need to sort out. Now, if the beta HCG is positive, that means the woman is pregnant. So this is confirmed that there is some pregnancy. But this pregnancy is really not seen or not visualized. So this is a pregnancy of unknown location. We don't know where this pregnancy is growing, whether it is growing or not. We really can't understand anything about it. Now, a pregnancy of unknown location could be a chemical pregnancy. What is a chemical pregnancy? Beta HCG is positive, but it spontaneously gets resolved on its own. So this is a chemical pregnancy. We really don't do anything, but slow growing, the beta HCG levels being positive, slowly they fall in titers, and this becomes negative. Or it could be an ectopic pregnancy. It could be a tubal pregnancy, ovarian pregnancy, or pregnancy elsewhere, which spontaneously gets absorbed, or there is a tubal abortion. So these things can happen to any women because there's an inconclusive sonography in such cases. So we really don't know what is happening inside. Now, what are the other names given to this pregnancy? It could be a preclinical embryo loss because we are not able to see that. It could be a trophoblast in regression because the trophoblast activity has started, the invasion started, but ultimately it got regressed. It could be a chemical pregnancy because it is only diagnosed on chemical basis, and non-visualized pregnancy because it is actually not seen on ultrasound. What is the actual incidence? Surprisingly, the incidence is quite high. Even in natural conceptions, 1/3 of all pregnancies that are implanted, 1/3, that is quite a high incidence, go unnoticed because the woman is not even aware that she was pregnant. unless she is trying for conception and she does that beta HCG, I mean the uterine pregnancy test frequently. There are a set of women who actually, you know, they come with a series of strips, you know, saying that, see doctor, this was a faint line, that this was a darker line, and this was a lighter line, and they have they come with all the strips in their bag. So in such cases, it may be diagnosed, but more realized after IVF, which has come into common practice. Now, IVF is so commonly practiced, and I think if we talk about 40, 45 years back, people were not even knowing about this entity, whether it existed or not. And since after doing IVF, we just do a beta HCG level, and if that comes out to be positive, and further we are not able to visualize the sac, then perhaps the diagnosis of biochemical pregnancy. Now, why biochemical pregnancies are so common after IVF? There could be various causes. Firstly, ovarian hyperstimulation in a fresh embryo transfer cycle. There is alteration in gene and protein expression, which leads to some endometrial asynchrony or maybe some endometrial problem in implantation. So this could be one of the reasons. It is more common in ICSI pregnancy, intracytoplasmic sperm injection. The likelihood of biochemical pregnancy increases because there is physical or biochemical disturbance of ooplasma or meiotic spindle, because whenever we are injecting the sperm inside the oocyte, probably there's some kind of disturbance which occurs. Or there could be injection of sperm carrying chromosomal abnormality. So we have not known, we just select the sperms, and that sperm may be having some kind of problem, and this may be responsible for biochemical pregnancy. The incidence quoted is 18 to 22% after fresh embryo transfer, and reported incidence of 27% in FET cycles, that is frozen embryo transfer cycles. So why so? Because in FET cycles, there are two schools of thoughts. Some people claim that it is higher in frozen cycles. Some people claim that the incidence is higher in fresh cycles, and it is still, you know, it has not been proved because there are no randomized control trials as yet. In frozen embryo transfer cycles, the endometrial alteration, which prevents proper embryo development and implantation, thus increasing the incidence of biochemical pregnancy. So whenever we are doing a frozen embryo transfer, then probably the always have to keep a lookout to rule out to see for biochemical pregnancy, because we are giving her hormones, which the estrogen, the progesterone, which may have its impact. And secondly, it is said that probably in frozen embryo transfer cycles, there can be some problem with freezing and thawing, or the cryopreservation as such can give rise to a biochemical pregnancy, although the incidence is lower after the present scenario of fast freezing, the cryopreservation techniques which are available, because the slow freezing techniques which were practiced previously had a higher incidence of biochemical pregnancies. But few people, they claim that more likelihood of biochemical pregnancy after a fresh IVF as compared to frozen embryo transfer cycle due to alterations in endometrial receptivity. We all know about the asynchrony, and therefore the occurrence of biochemical pregnancy, which may be there. Now, what is the mechanism of biochemical pregnancy? What actually happens inside the body? Soon after fertilization or embryo transfer, the embryo begins to secrete serum beta, the beta HCG, and thus the serum beta HCG levels rise. Trophoblastic reaction and embryo invasion results in continuous rise in beta HCG levels. Patient's test is positive in early stages, but further growth stops, thus preventing any further evidence of pregnancy on ultrasound. So it is said that the process starts, but it gets halted, or there is some interruption in further going ahead of this pregnancy, and therefore biochemical pregnancy. Truth is, biochemical pregnancy is a conception, but actually very, very early miscarriage before it is realized. So the pregnancy miscarries. It may be because of the genetically abnormal embryo developmental arrest or degeneration. Theoretically speaking, death of an embryo after implantation in the uterus before its visibility on ultrasound. So something happened inside, but ultimately everything got shattered, or there was some arrest or degeneration, and or it could be a spontaneously resolved ectopic gestation. How do we really diagnose biochemical pregnancy? As pregnancy is not visualized, how are you going to diagnose? Most biochemical pregnancies go unrecognized, especially in a natural cycle, probably because women don't test the serum beta HCG level, they don't perform. They just experience a little heavier flow with little cramps and maybe little delayed, 1 or 2 days of delay. So these are the women who might have an unrecognized biochemical pregnancy. Otherwise, a low peak serum beta HCG levels, less than 100 international units. If after an initial good beta HCG, sometimes the beta HCG levels are quite good, but the levels decline after say 5 to 7 days. If you repeat the level, then the levels either decline or they are steady. And this rapid fall in beta HCG levels may be diagnostic of biochemical pregnancy. In spite of beta HCG test positive, pregnancy fails to progress to a point of USG confirmation. So in spite of the beta HCG showing good levels, but then the pregnancy, it is more likely that these pregnancies may be ectopic. In IVF, if pregnancy cannot be visualized after 5 to 5.5 weeks or 3 to 3.5 weeks after embryo transfer, then these pregnancies may be ectopic pregnancies, as has been, that could be diagnosed. So these are the conditions where you suspect biochemical pregnancy. Now, the most important and the most difficult zone that we are coming into, the etiology or the causes of biochemical pregnancy losses. More or less, whenever a couple comes to us, we just try to explain them. The problem could be in the wife, that is maternal problem. The problem could be in the husband, that is paternal problems, or there could be some problem with the embryo, that is whenever we get the egg, the sperms from you, they were normal, and then there was some mutation, some changes that occurred which led to biochemical pregnancy. Now, what could be the maternal problems? It could be genetic abnormality of oocyte. It could be some problem in the paternal, from the paternal side, that is the husband may be having some problem. In such cases, sometimes, people say that, we've done a genetic test, the karyotyping reports are normal. So still, even if the karyotype is normal, still we have not tested the oocyte and the sperms. So there could be some problem at the gamete level. So genetic abnormality of the oocyte, from paternal side, sperm DNA damage, which is a very special entity which has to be looked after. And from embryo, it could be some chromosomal aneuploidy. It could be aneuploidy or translocation, which is balanced translocation, which is found in the parents, which could give rise to some unbalanced translocation in the embryo. Or this problem could arise de novo. If we talk of the maternal problems, there could be some other problems like advanced maternal age. This could be the only factor that we find, because with advanced maternal age, there is a battery of things which come into our mind regarding so many things, the oocyte, the uterus, and so many things can be affected and giving rise to a biochemical pregnancy loss. Now, there could be immunological factors which are there. There could be some endocrine factors which may have been diagnosed, which are unknown. And there could be some uterine factors, anatomic abnormality, presence of hydrosalpinges, poor endometrial lining or receptivity. It could be presence of some infection. It could be antiphospholipid syndrome, APS, that is the acquired thrombophilias, or it could be the risk factors which may involve extremes of BMI. Either the woman is too obese or she's too thin. There could be some smoking, which is becoming very common nowadays in youngsters, or it could be related only to stress, which may be there in the women, and that may also lead to chances of biochemical pregnancy. Apart from all these reasons that are known, there is one more very important reason which has to be looked after, and that is suboptimal lab culture condition. So that if suppose in a case, like you have 2 or 3 biochemical pregnancies in a row in different patients, then probably you just check your lab. If there's anything wrong, you have to note and just rectify so that this problem is solved at the earliest. So this is a condition which is often ignored, and the clinicians like us don't even think sometimes that there could be some problem which is happening in the lab. Now, if we come to the chromosomal problems, almost 50% pregnancy losses are due to chromosomal abnormalities, and they are mostly aneuploidies. These may be genetic, that is present since beginning, but more often or not, they arise de novo. That means the oocyte was normal, the sperm was normal, there were some changes in mutation and the embryo became aberrant, and there's some aberration in chromosomal structure during development. So this is also very, very important. That has to be kept in mind. There could be trisomies, seen most often in cases of advanced maternal age. More than 35 years of women, 16, 18, are known to be the cause of early pregnancy losses. There could be Y chromosomal abnormalities, like translocation in Y chromosome is commonly detected due to defective spermatogenesis. So this could be one of the factors, or it could be genetic problem related to factor V latent. This mutation is genetically inherited, predisposing the affected individual to thrombosis. So all these genetic abnormalities should be kept in mind. And the answer is pre-genetic screening can be offered, or nowadays pre-genetic testing is what is called in the latest term, can be offered to rule out chromosomal aneuploidies in embryos before the transfer. Now, what are the prognostic factors? First and foremost is the age, which is most important determinant. Women's age and aneuploidy rate. We know that as the women advances in age, chronic aneuploid abnormalities in the oocyte, the aneuploidy rate is higher. There is reduced implantation rate and reduced ongoing pregnancy rate, and there are increased chances of biochemical pregnancy. So women's age is the most important indicator, and therefore it is said that higher rates of biochemical pregnancies losses is seen in advanced maternal ages. Now, other factors apart from increased rates of aneuploidy could be diminished ovarian reserve, because the leftover oocytes are not good. And if we see a diminished ovarian reserve, then also we can relate it to the occurrence of biochemical pregnancy. Or there could be increasing rate of embryo endometrial asynchrony. So these are the cases where these are the prognostic indicator, that is age is the most important one. Apart from age of the women, oocyte. There could be some genetic abnormalities in the oocyte to explain the incidence of biochemical pregnancy. The oocyte may be genetically abnormal. Not only this, but there could be some meiotic spindle integrity problem, mosaicism, non-disjunction in the embryo, that may be the factors. And these are the mechanisms by which the the problem occurs. And genetic makeup of the oocyte and meiotic spindle integrity are responsible for defective embryogenesis. Now, there Normally what we see is morphologic indicators of oocyte abnormalities. We could see a CLCG, that is centrally located cytoplasmic granulation in the oocyte. And it is said that almost 50% of such oocytes have aneuploidy. It could be condensation of endoplasmic reticulum, it could be a polar body abnormality, or it could be some kind of cytoplasmic abnormalities that are seen in such oocytes. Now, if we come to the male factor, it could be some problem with the sperms. It could be chromosomal aberration, it could be single gene mutation, and abnormal sperm morphology. So it is very important. Sometimes, you know, the couple comes to us and says, is it really required? Because my wife is getting pregnant. So do you think really that the sperms are to be tested? Yes, definitely, because they may be the cause of biochemical pregnancy. Now, what we see in clinical practice is the morphology, which is very commonly seen. It is said that morphologically abnormal sperms in a severe male factor, they have a higher incidence of aneuploidy. So all these things need to be seen, although sometimes we don't go in for genetic test, but cases which are very poor in morphology or severe male factor should be evaluated properly. Now, meta-analysis of 11 studies on sperm DNA damage indicated an association of significant increased risk of pregnancy loss after IVF and ICSI. Now, what could be the possible mechanism? Sperm DNA damage, as indicated by high DFI, sperm SACA or HELO testing, abnormal packing of sperm chromatin, which leads to an abnormal embryo. So there is some problem with the embryogenesis and the abnormal embryo fails to implant, or maybe it shows a biochemical pregnancy. Now, third more important factor is embryo. It could, because normally what we see in the lab is the developmental stages, the fertilization, the cleavage, the morphologic, the blastomeres, the number, the size, and so many morphologic criteria are taken into account, and then the best embryo is selected for transfer. But we could also, if there is a high suspicion of biochemical pregnancy, or in a case of recurrent miscarriages, we also do a genetic testing. Now, if the embryo is euploid, the age is a very important indicator, because in a women of less than 25 years, the aneuploidy rates are less, that is 63%, and 32%, 63% of euploidy rate and 32% of aneuploidy embryos. And as the age advances, the aneuploidy rates increases. And therefore, there is receptivity and selectivity of which we are very well aware of, ultimately to result into a successful pregnancy or an early miscarriage or a biochemical pregnancy. So we want only the best embryos to implant and further progress to a healthy pregnancy. And we rather don't want these embryos which are abnormal to implant, and that is checked at the level of endometrium also. So the embryo quality and the age will determine the final pregnancy outcome. There could be some uterine factors. Now we see this very, very commonly. And uterine factors, now what we do is, as soon as the woman comes or the couple comes, at the first visit only, we try and see, evaluate the women, and we take the history and we do a good transvaginal sonography. It could be a 2D, added 3D, 4D sonography, which rules out a lot of things. We can also rule out any uterine anomaly now, a presence of septum, arcuate uterus, unicornuate uterus, didelphic uterus, whatever. So any congenital anomaly of the uterus can be diagnosed in the first go. Presence of myoma, which is distorting the endometrium, or a large myoma which may be present, or a polyp which is occupying the entire cavity, or multiple polyps are there. So all these things can be diagnosed by when you do your own scans. It could be an adenomyotic uterus or presence of endometriosis, which can very well be appreciated if you are doing your own scans. So in such cases, we already have in mind that there could be some problem with the happening of pregnancy. And this is something which is very, very important. It could be presence of hydrosalpinges. Many a times we can see hydrosalpinges on transvaginal sonography also. And if it is there, then probably we can talk to the couple and treat it, and rather we can do something about it. Another important factor is a presence of thin endometrium. It could be because of the previous endometrial traumas, prolonged use of OCPs, giving rise to some kind of impaired blood flow and atrophy. And it could be because of so much of tuberculosis, which is there in our country, infections, and recurrent DNC, so many other things which are seen, which are responsible for thin endometrium. Now, this was a very interesting study, although the number of cases were very small, 81 women, and biochemical pregnancies occurred in 21.9% of cases when endometrial thickness was less than 9 millimeter, and there were no biochemical pregnancy noted when the endometrial thickness was more than 9 millimeter. So I think this gives us the importance of noting the endometrial thickness in such cases. So this is something which is very important. Apart from this, there could be some infection or chronic endometritis. We cannot complete the discussion without mentioning chronic endometritis. When we are talking about the uterine factor, there could be some common pathogens and many more. I have just sorted out a very small list, mainly Staphylococcus, Streptococcus, E. coli, and Mycoplasmas. Now, the more important is how do we really diagnose chronic endometritis? Diagnosis is the histological confirmation after a hysteroscopic visualization. Now, what we actually see in a hysteroscopic examination, I'm sure we all do hysteroscopy before taking the case for ART, or in such cases where recurrent pregnancy losses are there or biochemical pregnancies are there. So we all do hysteroscopies. And in such cases, we can see either some kind of endometrial edema which is there, or presence of micropolyps, or there is hyperemic. There are hyperemic areas which are there in the endometrium. So this is a hysteroscopic visualization, but finally we need to confirm it through histology. It could be bacterial cultures, or it could be immunohistochemistry. Now, there is a presence of plasma cells, which is very, very important. It is a rather diagnostic test, and we always try and tell our histopathologists that kindly see and rule out chronic endometritis, because I'm able to see certain changes in the hysteroscopic evaluation. It could be molecular diagnosis is more promising, like RT-PCR, to diagnose bacterial DNA, which has a sensitivity of 75% and 100% specificity. So I think apart from these, we can go in for a molecular diagnosis, which is more confirmatory. Now, if we think about other causes, because we have to keep thinking in such cases what actually has gone wrong, and why this patient has had a biochemical pregnancy loss. It could be an immunological cause. Maternal immune system is very important determinant. What is accepted and what is rejected, it all depends upon the immunological system of the mother. A high density of uterine natural killer cell. Whenever we think about immunology, there are so many things: cytokines, leukemic inhibiting factor, integrins, and so many, you think about HLA. But mainly what we diagnose and what we see is the NK cell activity, a high density of uterine NK cell activity. Abnormal increase in peripheral NK cell activity is associated with recurrent biochemical pregnancy. And why? How does it happen? Because they remodel uterine spiral arteries, responsible for successful placentation by regulating trophoblastic invasion. So ultimately, presence of these cells inside the uterine cavity, they somewhere prevent trophoblastic invasion. And that is the reason why these cells, these immunological causes may be important. And we normally take a endometrial biopsy pre-menstrually and then send for uterine NK cell detection. The more important is downregulation of NK cell has been associated with favorable pregnancy outcome, which is finally confirmatory that maybe the immunological factor was the sole factor which was responsible. It could be autoimmune antibodies. So the topping the list is antiphospholipid antibody, antithyroid antibodies. It could be peroxidase or thyroglobulin. It could be anticardiolipin antibodies. It could be anti-beta-2 glycoprotein 1. It could be lupus anticoagulant. And all these are supposed to impair the blood circulation at maternal fetal interface. Not only, we always relate it to the blood circulation, but there's very important factor. It could also generate inflammatory immune responses, which may be responsible for a presence or occurrence of occult biochemical pregnancy. So this is something which is very important. And variable immune modulation treatment should be offered to patients who have experienced a repeated biochemical pregnancy loss after IVF and that are suspected having aberrant auto or alloimmunity responses. Now, apart from this, there could be hereditary thrombophilias. I believe that hereditary thrombophilias may be responsible for a little clinical pregnancy losses more often, but just to complete the list, these could also be there in the to rule out, although we don't actually recommend carrying out these tests very often in a case of recurrent biochemical pregnancies. Now, as I said earlier, lab conditions are something which are very important that have to be considered when you're not finding any cause. And maybe just look into the lab, talk to your embryologist, and just see whether we are working in optimal culture conditions or these conditions are suboptimal. It could be related to air quality. You know, when sometimes I have a friend who just kept calling that, you know, I'm having a lot of recurrent miscarriages and maybe biochemical pregnancies. And then we check air quality. Another thing which has been mentioned is HIPPIes containing media reduces the implantation rates and pregnancy rate. We generally use HIPPIes, but then the use should be at a minimal times. pH shock when improper handling of media or improper percentage of carbon dioxide in the incubator. It could be a temperature shock, improper handling of oocyte and embryo. I think we are all aware of these things, but then they have to be checked. Now we come to the most important aspect. We have diagnosed or we have not diagnosed what went wrong, but what is the treatment? Now the treatment can be divided into two parts. The treatment for present pregnancy. For present pregnancy, actually no specific treatment is required because the chemical pregnancy is as such short-lived. And so there's no time to treat because the beta HCG levels were normal. Beta HCG levels came down and finally everything went away. And we just were, you know, witnessing a storm and that has subsided. Follow up with beta HCG level, test a declining level to detect to undetectable values in order to differentiate it from ectopic pregnancy. Suppose you have a beta HCG and the second time there's no doubling or it's a very trivial rise. So we definitely follow up these levels because it could be ectopic pregnancy. And if it is so, then we always counsel the patient. It may be a non-viable pregnancy or persistent pregnancy of unknown location. Sometimes we see this and the pregnancy levels are there in the blood. The serum beta HCG levels neither rise nor fall and they plateau. So in such cases, sometimes we give methotrexate, which may be required. to abandon this cycle or pregnancy. Prognosis for future pregnancy is not affected. We have to tell this to the patient, and we constantly, because it's such a disappointment for the couple that, and many times the women says that, oh doctor, I wish I was not pregnant at all. Why did this happen? So we have to tell them that, okay, it's not a good thing, but then you don't worry, because the prognosis for future pregnancy is always better, and it's you ultimately everything is going to be all right. What are the guidelines for treatment? The ARM and ACOG don't recognize biochemical pregnancy as mass miscarriages, whereas ESHRE treats it as a pregnancy. If one biochemical pregnancy loss, there's hardly any treatment which is required. If there are two biochemical losses, little is needed. ESHRE says treat. If there are three biochemical losses, treat as recurrent pregnancy losses. So this is very, very important, that if there is a biochemical pregnancy and if it is recurring, then we have to do something. We have to treat such women. What to do in the next pregnancy? This is a $1 million question. Who is going to answer this? There is no evidence-based trial of any particular way of treatment. So we actually don't know, but then what are the things which are available to us? First comes always, as is known, is lifestyle modification. If the woman is very obese, or even if the husband is very obese, and maybe they are suffering from diabetes or high blood sugar, hyperinsulinemic, they are advised to go for exercises, shed off few kilos, and then come for treatment. And we just have to explain them that probably the prognosis next time may be better if you do all these things. A proper diet and nutraceuticals may be given, and the importance of diet and nutraceuticals is beyond the scope of discussion, but definitely it is going to help. Smoking and tobacco, because they are going to increase the chances, and the further pregnancy prognosis is not going to be too good if they don't stop smoking, tobacco, alcohol. And of course, the underlying metabolic and endocrine causes have to be corrected, and before taking her up for next or subsequent pregnancy which is being planned. Now, this forms a very important aspect. Whenever we have a biochemical pregnancy, we always check with the lab whether in vitro developmental ability of human embryo that was observed indicated that behavioral and mechanism involved in genetic causes of BPL, and embryo quality, PN morphology, and cleavage should have been known. Slow growing embryos have a higher aneuploidy rates. So just check with your lab person, how are the embryos, how are they growing, how are the cleavage, what exactly happened, and the complete story has to be known. Progression to blastocyst and selection of best embryo, higher aneuploidy rates in embryo which fail to progress to blastocyst. So all these things are to be known, whether the blastocyst can go formed or not, and what stage you transferred the embryo. So the complete feedback from the lab is required. Now, therapeutic interventions, strategies during IVF. If you have good quality embryos which are morphologically and developmentally normal, we can of course change to blastocyst transfer instead of cleavage transfer. The implantation rate is 25% versus 12.4% as reported. So this is one strategy which you can adopt. Fresh versus frozen embryo transfer. We can see that the implantation rates, the clinical pregnancy rates, and the ongoing pregnancy rates are higher with frozen embryo transfer. So what you can do is, for the next or the subsequent pregnancy, you can plan or you can cryopreserve all the embryos and take her for frozen embryo transfer. That is a segmental approach. If suspected etiology of recurrent biochemical pregnancy after IVF in these cases were related to decreased endometrial receptivity, which would be consistent with previous report of compromised embryo receptivity, and associated biochemical pregnancy. So more or less, precisely speaking, if you have some suspicion on decreased endometrial receptivity, or you don't have any other reason to say that this could be any other reason for biochemical pregnancy, there could be various methods which can be implemented that may improve endometrial receptivity. First of all, change the protocol of controlled ovarian stimulation. It is said that changing the protocol may help. Freezing and thawing of embryos, segmental approach, as we have already discussed. Endometrial stimulation, that is scratching, which is now not a lot of, there was a big hype in between, and then finally we have all realized that it doesn't work in all the cases. And previously we were doing endometrial scratching for previous failures and cases where the results have not been so good. But now again, I think we have accepted that it really doesn't work. PRP and GCFS instillation and injection, this still is little more hopeful because we do PRP in quite a bit of our cases, and we have found a very good result. And probably in the literature also, this is coming up in a big way. And there are many studies which indicate that it really helps. So it could be either instilled in the same cycle before the embryo transfer, before the embryo transfer on the day of pickup, or it could be in a cycle prior by hysteroscopy, the subendometrial injections that we can use. PRP, it really works. And if we are suspecting the low receptivity, the compromised endometrial receptivity, and we can also test ERA, which can give us an idea about the personalized ideal time for window of implantation. Apart from this, PGT, that is pre-genetic testing for aneuploidy. Normally, the selection of embryo transfer were based mainly on the morphologic criteria, but many women failed to achieve pregnancy. You know, the embryos were normal, everything was normal, but despite of everything being normal, the women did not conceive. The main purpose, so in such cases, PGTA may be helpful. The main purpose of PGTA is to screen embryos for whole chromosomal abnormality. Previously, FISH was used, but then we know that it is no more practice because very less number of probes and few chromosomes can be tested. And nowadays, we have expanded our assessment criteria for chromosomes. The tests have been, more tests are available, and they can be array comparative genomic hybridization, that is CGH, or next generation sequencing, which is a final test which can diagnose a lot of aneuploidies, qPCR. These are few tests which can be practiced, obviously only in indicated cases because they are very expensive. This was a study by Takeshi Sato, which was published in Human Reproduction 2019. And this was a study on cases of recurrent pregnancy loss. In such cases, there were two groups, PGTA, 41 women, and non-PGTA. Such women were divided into two groups. A group had a PGTA test and other group non-PGTA. And these were the number of cases. And the embryo transfer was performed in PGTA in only 51.2%. So only in half of the women, the embryo transfer could be performed when the biopsy was taken, biopsy was done, because most of the embryos were, they were not having embryos, or the embryos were not normal. Whereas in non-PGTA group, 97.3% underwent endometrial biopsy. There was a pregnancy, biochemical pregnancy loss, the rate significantly decreased to 12.5% as compared to 45% incidence in non-PGTA group. So this is really alarming. And because the embryos which are not good, or the embryos which were not formed up till that stage, those cases never had an embryo transfer. And therefore this rate really reduced. Clinical pregnancy rate per embryo transfer was 66.7 as compared to 29.3. Miscarriage rate was significantly reduced. live birth rate per embryo transfer was very high because less number of, suppose we had 10 patients, only 5 patients underwent embryo transfer. So live birth rate per embryo transfer was significantly high, but live birth rate per patient remain almost the same in both the groups. So to have a final word, no difference in live birth rate per patient between PGTA and non-PGTA group. Live birth rate per embryo transfer was significantly higher in PGTA group. So per embryo transfer, there was a improvement, and PGTA reduced the biochemical pregnancy rates significantly. So in cases of which are indicated recurrent biochemical pregnancy losses where you're not finding any cause, probably PGTA may work. Now finally, the treatment options for recurrent biochemical pregnancy, to summarize, it could be the maternal or others. In maternal conditions, the intervention, if suppose you have an anatomical problem, you know, this patient had a biochemical pregnancy, sometimes when the women comes to us, they are not ready for removal of fibroid, they are not ready for salpingectomy if we see hydrosalpinges, because they've had laparoscopy twice, and now they don't want laparoscopy, they don't want anything, they just want to go in for IVF, and they are not willing. But then finally, if we've had a biochemical pregnancy, in such cases they become ready for salpingectomy, they remove the fibroid and then take her for subsequent IVF conception. Polyps are removed, and suppose there is a poor endometrial growth, then probably we can treat her on some lines to improve the endometrial lining. If there are thrombophilias, whether hereditary or maybe acquired, then we can give her low molecular weight or heparin or low dose aspirin, because we are all aware of presence of thrombophilias may compromise the result, because they have a cascade of coagulation problems, and therefore there's a hypercoagulable state. So in such cases, we have to treat the women with low molecular weight heparin or low dose aspirin. There's one more issue which can be, I think, discussed, that is empirical use of low molecular weight heparin on low dose aspirin. With heparin, a lot of studies have been done, and they have found that probably if we really don't find any cause, and such women after 3 losses or 2 losses of recurrent implantation failure or maybe biochemical pregnancy, we empirically start these drugs, probably they may have its effect, but it has not been proved. So still we do not recommend the use of low molecular weight heparin empirically. Now, as far as the genetic problem is concerned, we have discussed ERA, we have discussed PGTA, we have discussed karyotyping. If we consider immunological problems, then probably we all agree on IVIG, which is used. Again, the indications have to be known because all these treatments are very expensive. Steroids and intralipids, I think we don't need to mention, because nowadays it has been proved through various studies that they should not be used, and they don't have any significant value in such case recurrent pregnancy losses. There could be some infection that we are dealing, so use of antibiotics, ceftriaxone or doxycycline, metronidazole. These are the antibiotics which are used for various organisms that are grown. There could be altered molecules of endometrial receptivity, so PRP instillation, as we've discussed, subendometrially or instillation in the uterine cavity in the same cycle, GCSF, which was again practiced previously in a lot of women, but now I think there are limited indications of its use. PGTA, if there's some problem with embryo, then aneuploidies. Male factor, stop smoking, and maybe IMSI would give a better chances, but again, there are various studies against its use. IVF protocol, optimize the protocol of IVF, that is we have discussed in length, and that needs to be changed. Now, what is the significance of biochemical pregnancy? How do they affect future pregnancy? Not necessary. Once a biochemical pregnancy will have difficulty in conceiving. Rather, women who have had a biochemical pregnancy in past will have a higher pregnancy rates in future. So this is a big, big hope for the couple, for the patient, and that has to be, sent across when you're counseling such couples. It means that the embryo, why? Because we have to explain them, because the embryo has reached peri-implantation phase, we invaded the uterus, produced pregnancy hormone, beta HCG has been detected in maternal circulation, thus representing a very, very, very early pregnancy. So it's a very big hope that maybe next time things will be better. Follow-up treatment, most important part, to identify predictive factors for biochemical pregnancy in subsequent conceptions. So this is very, very important. Next question which comes from the patient is, how soon can I get pregnant again? Women can attempt pregnancy almost immediately after an early pregnancy loss, and you don't have to tell her to wait for 3 months, 6 months and go home and do nothing. You can definitely call her and treat her again. According to American College of Obstetrics and Gynecology, women may ovulate and become pregnant as soon as 2 weeks after her pregnancy loss. So she doesn't need to wait for a very long time. So final conclusions, physicians as well as patients are under great pressures to know the cause of biochemical pregnancies and treatments for future pregnancy attempts. Although it sounds like a false pregnancy, a lot of times, whether I was really pregnant or not, how is it possible? There's a very nice article by Dr. Goody, little bit pregnant. How can it be a little bit pregnancy? As if I was like little bit pregnant and finally it all vanished. How is that possible? So not only meticulous workup, but also communication with the lab is very important to find out the cause of this mishap or pregnancy loss, and treatment for next pregnancy is again a very important aspect. Biochemical pregnancy is definitely not a success, but surely a good omen, which is very important to be conveyed to our patients, as they are positive predictors for future pregnancies, as women who has had a biochemical pregnancy or a chemical pregnancy in the first IVF are more likely to have a successful pregnancy in the subsequent IVF attempt. So more or less, it's a hope, and that should be kept and that should be conveyed to the patient for sure. With this, I would like to thank you from the team, Asian Institute of Infertility Management, Indore, for joining me for this webinar. And subsequently, you can post questions that are there, because we can definitely have a session of question and answers in future for this topic. Thank you very much.